I suspect most of the room knows what measurement-based care is. This probably isn't an audience that needs a full definition of it. And so my goal for today is I want to give as much real-world insight into what's actually happening in measurement-based care in the market. There's a lot of talk about it, but we at Greenspace get to see it every day. So my goal is to share what we see every day and our vision and what we see for the future. I'll very briefly just talk about Greenspace for those who are not familiar. In short, we exist to empower organizations to implement measurement-based care, to transform the way that services are accessed, measured, and delivered. Greenspace's story, we actually didn't start initially. The concept was not to be a measurement-based care company. The initial concept, partly out of my own personal experience, was to build a telehealth platform. And when we went to go talk to 200 clinicians before we ever did anything, it was a secondary element where we said, look, if it's going to be a telehealth platform, you're going to see clients remotely, let's build in a tool to measure and track outcomes along the way so you have a sense of how people are doing. And without exaggerating, the feedback was the same across the board. It was 95% of clinicians saying, look, I would use the telehealth with a couple clients. Obviously, pre-COVID, and the world has changed a lot. But tell me about the progress tracking measurement, because I know I'm supposed to do it. I know it leads to better outcomes, but I just don't do it today because it might mean doing these scales by paper and pen. I'm not really sure what to do. There's no simple way to do it. And so ultimately, that's where we started. We know that measurement-based care has a huge impact on treatment. It's largely borne out in research, much more than in practice to date. And so our goal was and is to reduce the burden of implementing measurement-based care. Let's make it easy, let's make it simple, let's make it attainable for clinicians. And to date, we've worked with almost 400 organizations across North America to implement measurement-based care. And the result, and I say this in not an obnoxious way at all, I have a really unique view on what's actually happening out there. There's a lot of talk about it, but I want to share today, what we're actually seeing. Now, I recognize 2 seconds ago I promised I wouldn't define measurement-based care, but I think it's important just to get a general understanding and ensure we're all on the same page. And so the way we define it is that measurement-based care is the routine collection and use of client-reported outcome measures throughout treatment to guide the clinical decision-making process. And there's 3 elements on the screen that are bolded that I think are worth highlighting. So the first is routine. So this idea that it's done regularly and consistently, not as a pre and a post tool. Second, that it's client reported. So clients, we're engaging them. They're the ones providing feedback on how they feel they're doing, and that's a critical component. And third, and probably most important, is guiding decision-making. So this idea that it's not a replacement for the clinician, it's not telling the clinician what to do, but it's a tool for the clinician to use to help inform the path forward for that particular person. And so ultimately, in our experience, introducing measurement at organizations hasn't been met with unbridled enthusiasm from clinicians. And you can probably understand why, because historically, it's been a pre and a post model where clinicians have been told to do this at the start, do this at the end. It doesn't seemingly benefit the clinician, certainly doesn't benefit the client, and so it's really been more of a data collection exercise. But our view of measurement-based care and where we see the world going is that it's meant to be consistent. It's meant to be part of the clinical treatment process so that it does actually benefit the client and the clinician, because if it doesn't, it's just data collection, which to us is not measurement-based care. And one final point on the guiding the clinical decision-making is that it really is not meant to be a replacement for the clinician's own judgment. The analogy that I often like to use is, imagine you were a care provider supporting somebody who had diabetes. You wouldn't just look at that person and say, hey, you look like you're doing better, let's adjust our plan and move forward. You would measure and track that person's blood sugar over time, and that would inform the path forward for that particular client. And the question that I have, that we have, is why should behavioral health and mental health treatment be any different? Why would we just assume we know the best path? Let's use all the inputs available to us to make the best decision for that particular person. So, it's not, there's an extensive body of research that supports measurement-based care. I don't think that fact is in question, but I want to just highlight a couple things here. So on the right-hand side of the slide, a couple statistics worth highlighting. So you see 3.5 times higher likelihood that somebody achieves reliable change. You see a 42% higher overall improvement in clinical symptoms and a 40% decrease in dropout or cancellation rates, including a 25% decrease in no-show rates. So pretty impactful. But on the left side, I want to highlight some factors that have some important clinical implications. So the first is that the more assessments clients complete, the more they improve. In our data, which includes over 3 million administrations of patient-reported outcome measures, we see a direct correlation between the number of assessments a client has completed and their level of improvement over time. So, the data is definitely supporting this. And then the second one, which we try to optimize for as best we can, is the more often a clinician reviews the client's results, the more the client will improve. Seems kind of obvious when we think about it, but it shouldn't be intimidating. It's not, the clinician doesn't need to review results for an hour and a half before the session. It can be a moment, it can be with the client, but the idea is that let's take the breath, let's take the second to review, and it will lead to better outcomes. So the current state, so where are we today? And what does that look like? And I'll highlight a few things here. So the first is that leveraging data is not yet the norm. As I said before, when measurement is done, it's most often a reporting exercise. It's a pre and a post score, which doesn't provide clinical value to the client and clinician. Just measuring start comes at the beginning and the end. It's not measurement-based care, and I think it's important to make that distinction. The second is that individuals who are receiving care are not typically given any tangible tools to understand their symptoms and monitor progress as they go through. So they're kind of operating in this gray space where they have to wonder how they're doing. And third, without the use of these client-reported outcomes, providers are relying only on their own judgment to make decisions, rather than incorporating the objective measures that can inform their decision-making with that person. It also makes it harder to identify situations where maybe a client was on track, but there's been some sort of change that impacts, what they might want to do with that person moving forward. And then lastly, this one should be kind of obvious, but effective QI is extremely difficult. If you don't have an understanding or visibility into what is and what isn't working, it's basically impossible to identify areas to improve and get better. So the question then is, what could a potential future state look like if consistent measurement were happening? We at Greenspace and myself, we can kind of cheat to answer this question because we've worked with so many organizations already to implement MBC. We can give some insight into what it actually looks like. And so 3 things I want to highlight. We see organizations using detailed objective intake assessments to determine people's baseline symptoms, allowing them to better triage and manage what programs or services somebody should be matched with. We see clinicians and admins being able to choose recurring assessments that meet that particular client's needs. So not one-size-fits-all approach, but picking the right measures or right assessments for that particular person at that particular time, and then adjusting their treatment as needed. And then lastly, at the management or supervision level, we see data being used to identify clients who are off track, who are maybe at risk of not having a good outcome. So rather than waiting 6 weeks later for a dropout, identifying that earlier and sooner, and also using that information to encourage collaboration and foster an environment of learning and improvement based on actual data. So we've talked about the ability to capture this data. What is the actual impact of it? And so what we see is an incredible impact across a few different levels. So for people in care, it allows those individuals to be more engaged in their own treatment process, reduces dropout, ensures people are accessing higher quality services. For individual clinics and agencies, it allows them to customize the care pathways based on actual objective outcomes. It lets them leverage the data, like we talked about a second ago, for supervision. It fosters that culture of learning and improvement. And it also allows them to share the effectiveness externally of their services with payers, funders, and other stakeholders. And at the health system or level where multiple organizations are working together collaboratively, it allows for a more connected system of care. So for somebody who's been receiving treatment previously, allowing their new clinician to see the outcomes that they've had before and use that to help inform the path forward. It also allows the use of data to inform program improvement and resource allocation. And then especially the larger the organization, it allows for the ability to monitor clinician effectiveness, and not in a punitive way, but in a way that then allows to tailor training, development, resource allocation accordingly. So look, we see every day at Greenspace the impact of measurement-based care. The research is very clear. The question then is how can you implement it successfully? And I appreciate that this is a daunting question in some cases. Based on the research and based on what we've seen through our implementation, we've developed what we call the 4 C's of measurement-based care. And the first is consistency. So, effective measurement-based care needs to be consistent. It needs to be done regularly through treatment, and then it can be brought into the session, by the clinician and the client. The second is customized. So it's important that the clinician's empowered to make choices about what assessments or measures that client's going to do. They don't need to necessarily have choice over all the measures or assessments, but if you're asking a client to complete measures that are not relevant to what they feel is important to them, it's not going to be particularly helpful. The third is client visibility. The client should have full visibility into their results. It allows them to better understand how they're doing. And quite frankly, if we're asking them to participate, if we're asking them to input all this information, why is it fair for them not to see how they're doing? We want to move away from the traditional electronic health record model where the client maybe doesn't have access to their own information. And on top of that, the research is incredibly clear that measurement-based care is most effective when client and therapist both have full visibility into those outcomes. And interestingly, if both don't have visibility into those outcomes, it's actually more effective if just the client has visibility, not just the clinician. And then lastly, collaborative. Measurement-based care should be collaborative. It should be a joint effort, a team effort between the client and the clinician, and they should be able to mutually agree on goals and the path forward. So now that I've given a bit of a sense on MBC, the impact from a research perspective, I want to share a few more tangible examples of what we see in practice. And so the first organization I'm going to highlight is an organization called Pinebrook Family Answers. They're a nonprofit services agency based in Pennsylvania. They're known for their children and youth services, including their school-based programs. And they use measurement-based care not only to improve outcomes, but they leverage their aggregated client reported data in three ways. The first is to identify gaps in their own services. The second is to collaborate as a care team, so more specifically identifying those clients that are not responding to treatment and then finding them a better path. And third, using the data to provide transparent reporting back to their board and funders. The next is Encompass Community Services, which is the largest community-based provider of health and human services in Santa Cruz County in California. And this one's particularly interesting because beyond the impact on patient outcomes, the key reason why they've decided to implement measure-based care is based on their commitment to increasing the equity of its services and help all clients have an equal chance at achieving a successful outcome. So given that they largely serve a Medicaid population, their clients have a wide range of experience with mental health services and are exposed to significant stigma in the community. And so the goal for them is to provide each client with transparent access to their own data so that they're empowered to communicate their own needs and own experiences to their clinician, ultimately ensuring that their voice is heard throughout the care process. And so this is their primary motivation for it. And then the last one I'll highlight is Meraki. So Meraki is a not-for-profit developmental behavioral health and education provider. They have over 700 locations and over 10,000 providers. And the three reasons why they decided to implement measurement-based care was one, first and foremost, to improve the quality of care. Two, to foster that more collaborative approach to learning and sharing best practices among their clinicians. And three, to support contract negotiations and discussions with payers around value-based care by being able to to demonstrate the effectiveness and impact of the services that they're providing. A couple comments on systems. So we work with a number of different systems and coordinated implementations. Two examples that I've shared here. One is the Northeast Behavioral Healthcare Consortium in Pennsylvania, and the other is the Community Behavioral Health Association of Maryland. Both interesting in their own right. So NBHCC coordinates the Medicaid Managed Care Program for behavioral health across 4 Pennsylvania counties. And they have 8 provider organizations working together in this initiative, and the goal is to implement in a consistent manner across the region. And the goals for the rollout are collaboration on those providers on that model, so ensuring some level of consistency across the region, generating a shared outcome data set that can be then used to generate benchmarks and standards moving forward in the region. And then third, using that outcome data to negotiate higher rates for providers that are demonstrating the best clinical outcomes. In Maryland, CBH represents over 90 community-based agencies in Maryland. In the first phase of the implementation, we support 20 of those agencies in implementing measurement-based care in a coordinated way. And their goals are, they're big believers in measurement-based care, so they want to implement it across all member agencies. They want to drive quality improvement using shared data, also benchmarking, and then a learning collaborative where all the agencies participate together to identify what's working, what's not, and sharing best practices. And then as well, leveraging that outcome data to support advocacy efforts at the state level. So we've established, the impact that measurement-based care can have at all levels. The question then is, how should you get started? And I recognize this is a daunting question because it feels like something new, something additional that we have to do as an organization. And while this might not be a satisfying response, the reality is that there is no single right answer. And it depends on each organization's objectives, workflows, client populations, and experience with measurement-based care. But what I'll say is that isn't a bad thing. Measurement-based care can be designed flexibly to adapt to any organization. It's not this thing that must be done in a certain way, or at least it shouldn't be. It should adapt to your workflow, to your organization, not the other way around. The reality is that, yes, we're in the earlier stages of measurement-based care having been implemented. Only 20% roughly of providers are saying that they're doing measurement. Our bet would be it would be probably closer to 5 or 10% if you use the actual definition of measurement-based care. But it's been done before, and the technology exists. The change management practices and experiences now exist for organizations to be successful. Many organizations, large and small, will say, look, we're going to do a big bang launch. We're going to do it with everybody straight away. And that's okay. But more and more, we're seeing organizations say, hey, we're going to start with this particular program, or we're going to start with this geographic region, or we're going to just start with these 10 champions who are really excited about measurement-based care. And what the phased approach allows is it allows organizations to show some initial impact data, can be aggregate, can be individual client results and outcomes, to generate excitement across the organization. But it also allows them to fine-tune their process. We actually worked with an interesting implementation recently where they picked just 10 clinician champions, and their rule was we're not letting anybody else do it for 4 months. And they had lots of other clinicians say, hey, we're ready, we want to try, we want to do it. And they said, no, you're not allowed to do it yet. So they almost created this element of scarcity and that we're doing this really cool thing, and it sort of built the anticipation across the rest of the organization. One example of a phased rollout, another example of a phased rollout is Nova Scotia Health Authority in Canada. So they're one of 2 health authorities covering the province of Nova Scotia. They started with a pretty simple rollout, 100 clinicians, 12 clinics. And what they wanted to do is they wanted to use the data that they captured in the first year to generate excitement across the rest of the health authority. And that's exactly what they did. After the year, they showed, look, here's the impact we're driving, here's how it worked, here's the feedback from the clinicians. And they've since grown from there to cover their full health authority at over 500 clinicians at all sites in the province. I'm obviously biased, but I think there is an incredible momentum towards measuring outcomes. Everybody that we talk to Whether they're ready to implement measurement-based care today or in the future, there's this general understanding that this is where it's going, because we need to measure outcomes. There's no reason that behavioral health should be any different than physical health in terms of using outcomes to make better decisions. But the reality is not going to happen overnight, and that's okay. My goal for today was to share some insight into what's actually happening in practice, and that there are really good things happening and that it is accelerating. I've had a lot of really good conversations so far today. We're in the back corner by the big green sign if anybody wants to talk more as we progress. But thank you so much for having me, and I think we have a minute or two for a couple questions. Oh, we've got one in the front.
Hi, my name is Obi. I now run a peer support network, but I used to do a measurement company, and we find it really hard to get people to pay for it. Payers don't pay for it, so it just adds the clinicians have to eat it in their margin. I wonder what you're seeing as we're shifting to value-based care, where this is going to become more important. You didn't mention that at all.
Yeah, so it's a really good question. So it is. We have the interesting view of we're based in Canada. I would say certainly the majority of our new customers are in the U.S. though, so we get the benefit of seeing both countries. And in the U.S., there's certainly an accelerating underlying factor in the fact that we are moving towards value-based care. The reality that nobody really likes to talk about out loud is nobody really knows how to get there just yet. But there's a general understanding that you need outcomes to be able to get there. And so some of the interesting examples that I can share of what we're seeing is not organizations taking their data and outcomes to payers and saying, yep, here's what we want, here's the contract we're going to do. But we're actually seeing more and more collaborative situations where providers are taking their measurement model, they're taking their visualizations and outcome measures to the payers and saying, look, this is what we're doing today. This is what we could be doing. What do you like? What could work for you? What are you seeing here that makes sense? What are you not seeing here? And then being flexible to take it back and define and adjust that process moving forward. So what I would say is what we're seeing is it's the early stages of data informing those conversations. But what we're seeing generally is that providers are more and more understanding of the fact that you need that data to engage in those conversations in a meaningful way, even though it's not a cookie cutter process yet to say, hey, we have this data, it will lead to this particular contract. How would technology like Greenspace work with a national provider that may have different outcome reporting requirements in each state? This is a really good point, and I think I made this point at the individual level, but the way Greenspace is designed is that there is no one-size-fits-all approach. It's not a single measure that must be used. There's a range of different measures that are available. You can set up different structures or protocols for different programs, different types of populations. So in the same way that you can modify the approach for individuals or groups of individuals, you can automatically generate the right reporting for the right stakeholders in each state. The second one, JAMA Psychiatry says the only benefit of MBC comes from patient and therapist review of data. How do you engage the patient? This is, I totally agree with this. This is probably the biggest part of what we do. Patients have the ability to create their own account. They can see their own data, but they don't have to do it independently. They can do it during session with the clinician. Everything that we do in the platform is gently nudging and pushing the clinician towards reviewing that information with the client, but making it really simple, not making it a daunting task, because whoever asked that question is absolutely right. Like the patient has to be involved, and we want them to see their own information. I think I'm getting kicked off, but thanks very much for having me, and I'll be in the back.